about your study and why it was important to take a look at TAVR in bicuspid aortic valve disease.
So as TAVR indication extends to younger and healthier patients, we are going to see more bicuspid aortic valve stenosis. Because amongst young patients that are undergoing surgery, almost half of the patients actually have bicuspid aortic valve. So these are patients that are born with 2 cusps rather than 3 cusps. So it was important for us to look at this subset because all the pivotal studies done so far have actually excluded bicuspid aortic stenosis.
Why is that?
That's because of the belief that it would be much harder to have proper expansion of these valves in a orifice that has 2 commissures versus 3 commissures. So that was the main theoretical reason to actually exclude this in the earlier studies.
And did you find that to be the case, that there are increased problems?
So what we did was we tapped into the STS-ACC TVT registry, which is a registry in the United States that captures every single patient that undergoes TAVR procedure. And when we look at this large registry of almost 90,000 patients that underwent SAPIEN 3 valve in a period of about 3 years, we found about 2,700 patients that had actually undergone bicuspid aortic stenosis. So we were able to compare the outcomes, the clinical outcomes, the hemodynamic outcomes in these patients with patients that had tricuspid aortic stenosis. To make it robust, we properly matched these patients so they were similar patients. Now, what we found was that at 30 days, the death rate was same, and this persisted up to a year. So at up to 1 year, the survival was similar. The stroke rates were somewhat higher. They were 2.4% versus 1.6% compared to the tricuspid cohort. Now, it's important to point out that most of these patients, indeed, a tiny minority of these patients actually use the embolic protection or cerebral embolic protection device, which is a filter that we tend to use, at least at our hospital now, in the current environment, almost routinely. So that can be impacted, I believe, in the future with the use of these devices. The other thing that we found was that the procedural complications were slightly higher or somewhat higher, but numerically, if you look at these, they are still less than 1%. So for example, the risk of open heart surgery because of aortic root injury was higher in these patients, but it was still less than 1%. So in patients who are at high risk for surgery, intermediate risk for surgery, we believe that this is a very reasonable trade-off, okay, because the survival is the same up to 1 year, and the other issues such as paravalvular leakage, pacemaker rates, they were not dramatically different. Okay, so all of these data combined essentially tell us that we can use this TAVR procedure as a treatment alternative, to surgery in some of these patients. Indeed, you have to choose your patients carefully, all right? So it is possible that in this registry we chose, or the operators chose, patients that were more favorable anatomy compared to the highest risk and very calcified anatomy. So I think what I'd like to point out is that this doesn't exclude the role of carefully screening the patients as we treat them with TAVR procedure.
So you said appropriate to consider in high or intermediate surgical risk patients. What about the young low-risk
That's
patients?
correct. So I think today we heard the low-risk trials just presented essentially showed that the TAVR is actually better and the preferred treatment. But these studies excluded these bicuspid patients. So are we going to extrapolate this data to the low-risk patients? I think that the right thing to do in some of the younger patients would actually be to do a randomized clinical trial. So I think that we can't, in a blanket fashion, extrapolate the data of this to the lowest risk patients and the very young patients with the very calcified valves. All right, so I think we must balance. What we've done using our data is we've busted the myth that bicuspid valves can be treated and should not be treated with TAVR. All right, when you have a 2,700 patient cohort with good outcomes, that's not the case.
That's a big deal.
Right? Do you rapidly progress now to the lowest risk patients, the youngest patients who may have very calcified valves? Perhaps not. I think we must study what are the anatomical subsets that are at increased risk, try and exclude them. And I think as we treat a lot of patients around the world, I think it is imperative that we generate high quality evidence with a randomized clinical trial in those patients.
And that would be with cerebral embolic protection device.
I would say that it would be reasonable, and I think it would be wise actually to use cerebral protection devices in those patients.
Well, thank you very much for taking the time to talk about your interesting study.